Ladies and gentlemen, dear colleagues, I'm Szőcs Gyula. I would like to share my PhD progress so far. My topic is investigating the safety and efficacy of surgical and conservative knee cartilage preserving techniques. About myself, I work at Uzsoki Hospital at the Department of Orthopedics and Traumatology. My supervisor is Gyula. Our vision is to decrease the number of total knee arthroplasties in Hungary, and we would like to achieve that by increasing the use of knee cartilage preserving practices. We have two ongoing projects right now. The first project is a meta-analysis, and it's the comparison of safety and efficacy of meniscal repair and meniscectomy during ACL reconstructions. Okay, about the background, you may have heard a lot about ACLs, but I will say again, anterior cruciate ligament connects the tibia to the femur, provides anterior, posterior, and rotational stability. There are around 200,000 ruptures per year in the United States. ACL reconstruction rates have been increasing. It's around 100,000 in the United States, and it's almost 4,000 in Hungary. During an ACL tear, there is a possibility for other lesions inside the knee joint. In around 55% of the cases, there is a lateral meniscus tear, and in 45% of the cases, there is a medial meniscus tear. Meniscus, what are meniscus? They are C-shaped fibrocartilage. They are found inside the knee joint. They have a role of increasing stability and in the distribution of load. There are two major operative treatments. One is meniscectomy, which is removal of the damaged part, but this can lead to instability. And the other surgical option is meniscus repair, which is basically suturing these parts, and this way we can keep stability. It has been shown that preserving or repairing the meniscus can prevent early onset of osteoarthritis, but still, in 94% of the cases, there is meniscectomy performed, and around 6% of the cases there is a meniscal repair. There can be a lot of reason behind this one. So our aim was to compare the safety and effectiveness of these two surgical interventions. We used the PICO framework to ask our questions. We were investigating patients with concomitant ACL and meniscus tear, and we are comparing the two surgical interventions. Our main outcomes was clinical score, Lisholm, IKD-SICUS, and we were looking for safety outcomes, septic complication, tunnel widening, but there weren't enough data for those. So our hypothesis was that meniscus repair is superior to meniscectomy during ACL reconstruction. We conducted the research in 3 main databases. You can see the search key, and we got more than 10,000 articles, and from these articles we selected 22 eligible full text. Here are the results. For results I would like to share is the Lisholm score. It's a patient-reported subjective outcome. It's used for assessing injuries. There are 8 items in it, and it's a score scale between 100 and 0. So you can see our results on the forest plot. In this forest plot, as you can see, we compare the changes from preoperative to postoperative results. So there are mean differences, but unfortunately we couldn't find a significant difference between the two interventions. As you can see, the mean difference is minus 2.6, which is considering it's a 100-point score system. It's neither clinically or statistically significant difference. Our next outcome was Q score. It's knee injury and osteoarthritis outcome score. It has 5 subscales, but it's also a point system between 0 and 100. If you look at the results of the 5 subscales, there is statistically significant difference in one of the subscales, but all of them are clinically not significant differences. We could separate the medial meniscal injuries and lateral meniscus injuries in case of the Q scores. So if you look at the medial ones, there were no significant differences, and we can see also the same at the lateral meniscus injuries. Our next outcome is the IKD-SICUS score. Just as before, it's a patient-reported subjective outcome between 0 and 100, and we have all the same answers here. This is also no significant difference. Last outcome was the KT arthrometer outcome. It's a device which examines the anterior translation of the tibia relative to the femur. So it examines sagittal instability. In this one, we also didn't have significant difference, but this one favored meniscus repair. For the summary of the article, it's a more comprehensive meta-analysis than before in this topic. We could include much more studies, and we had several outcomes as well as medial and lateral meniscus. The limitations were the main limitation, unfortunately, there were no RCTs available. Mostly retrospective studies could be included. In the studies, there were different time to surgery times. There were different follow-up times. It was between 1 and 2 years, and there were different ACL reconstruction techniques used. So our conclusion is that based on our result, we did not find any significant difference in the efficacy of either surgical intervention. Our implication for practice is that they can be just as useful and good based on patient-reported outcomes if we look at the short and mid-term. Our implication for research is mainly that we need any RCTs in the topic. Different meniscus ruptures should be treated and studied differently. There should be different follow-up times and different age groups also, because the age groups were also not specified in the articles. So the manuscript is now under review at Orthopaedics and Traumatology surgery and research paper for the last 6 weeks, so I'm hopeful they will have a positive answer. Okay, next project is investigating the safety and efficacy of intra-articular injections in the treatment of knee osteoarthritis. We are planning this to be a network meta-analysis. A little bit about the background. Osteoarthritis is a degenerative joint disease, and it results from breakdown on joint cartilage and underlying bone. The most common symptoms: joint pain, decreased range of motion, and swelling. Osteoarthritis is affecting around 30 million people in the United States alone, and globally we can say that 80% of all osteoarthritis cases is somewhat regarding to knee osteoarthrosis. Main treatments for them can be either surgical, which is basically total knee arthroplasty, or it can be conservative. One of the mostly used conservative therapies is intra-articular injections. They present a low risk of harm. They're providing short-term pain reduction and improved joint function. There are a lot of types of intra-articular injections that we use: corticosteroid, platelet-rich plasma, hyaluronic acid, botulinum toxin, many more. And also there are many more subgroups of this kind of injections. But despite having this much option, there is no clear recommendation in the literature today which one to use. Recent studies showed great success when they were using combination of hyaluronic acid and PRP. So our aim was to compare all these different types of injections. Also, we use the PICO framework just as before. We are investigating patients with knee osteoarthritis, and we want to compare the treatment of PRP combined with hyaluronic acid to the other intra-articular injections. The outcomes are going to be mainly clinical scores. So our hypothesis was that PRP combined with hyaluronic acid will be superior to the other options. We conducted our systematic search this year in the 3 major databases. Now we are doing the selection process. This is our ongoing process right now. Thank you for your attention.
Regarding your first project, so you found actually no difference between surgical procedures. Does it affect your present protocol at all?
I would say no, because our protocol...
So this is just a confirmation that you are in a good track.
Yeah. So I would say we have the same number, like probably 80% of meniscectomy, 10% of meniscus repair. So if there is no difference, we're not going to make more meniscal repairs probably.
It is still quite important, just to strengthen the evidence, what you actually previously showed, and that is happening. So this is not a weakness of this, but just to see that there are clinical consequences of this.
I would argue a bit with that. You saw my sports surgeons in Eger on the domestic orthopedic congress. They started even refixation with the meniscal root, telling me this is a really expensive method. They just threw away the equipment after that. To the hospital director, they want to persuade me to pay, because in long run it is a very good and you can slow down the osteoarthritic changes later on. One of their case was introduced there. He was 55 years of age, starting with the osteoarthritic changes. And being an orthopedic surgeon, I used to argue with them, why to refix the medial meniscus or lateral meniscus root when the patient is old, when the osteoarthritic changes already have started. And they say that the literature says that you have to refix the meniscus. And I have just seen in your case that reconstructing the ACL ligament, it doesn't really matter whether you remove the medial meniscus or you reconstruct refix the medial meniscus. No real difference between the results. What about the late results?
Well, first of all, unfortunately, these are 1 to 2 years of results. So medium term, there is no difference. We are very interested to see the longer term, but there were no real literature available, unfortunately, or a good level of literature. But we included one article which compared the ramp injuries of the medial meniscus and lateral meniscus, so the base root injuries, with non-operative and suture, and they had basically the same results.
The concept was in the past, you have to repair the meniscal tear if the patient is younger to slow down the osteoarthritic changes. Does it affect the everyday practice, your result?
Well, it affects in the sense that we would like to know what to do, because there are no clear guidelines. The guidelines say that if the patient is younger and have a meniscus tear, try to suture it. But nothing like so-called real evidence behind it, or say which age group you should do. It's completely on the practitioner, and we don't believe that's a good thing.
So congratulations first.
Thank you very much.
It was a nice presentation. Both topics are hot topics today. My first question is a little bit different from your question, Laci, because you were asking generally refixation or not refix the meniscal tear. I wanted to ask you, it was a little bit shut down, that is there any difference if the anterior cruciate ligament is torn or not? So without the turn of the anterior cruciate ligament, generally, have you found some evidence in the literature that refixation or removal of the meniscus has just the same result if they are done in a proper way and in a good indication, because both are related of these. And these results are changed by the turn of the anterior cruciate ligament or not?
What the literature says is in just a simple meniscus tear, so isolated meniscus tears, there are RCTs available. And in that case, they say that the meniscus repair in a younger age group can be beneficial. But in this case, the question was, if we have the ACL tear, the knee joint is going to be more unstable. And if we do the ACL reconstruction, maybe there is no stability enough to heal the meniscus.
So for me,
it's also in isolated cases, if the ACL is intact and its knee is much more stable, then it will have better results, better outcomes than with ACL.
So for me, it's of great importance because the whole situation changed apparently if the anterior cruciate ligament is turned. If it is not turned, then to repair the meniscus has a positive effect for the patient. If the anterior cruciate ligament is turned, then it is the same stuff. So I think that it is, for me, a new message.
Yes, I'll come back to your second study about the injections. What is the usual, most used injection in Hungary? Do you know this?
Well, it's between corticosteroids and hyaluronic acid,
Okay.
or maybe the combination of those.
Okay. And do you see a lot of complications, especially infections, arising by that?
So in our practice, it's very low, I would say.
Okay. I think that's also what the literature is saying. It's less than 0.2 or roughly 0.1% because there are so many injections been done all over the world. So it doesn't seem to harm the knee. And on your personal advice, how many injections do you recommend the patients before you stop using them because they show no positive effect?
Usually in case of hyaluronic acid, we give them 12 to 6 months. And if it's not working or works like for 3 to 6 months, then we should advise surgery.
You go to surgery then? Or recommend surgery? Depending.
I mean, obviously you try the other conservative treatment options.
And maybe one last question, interestingly, do the patients have to pay for this in Hungary? Or is it the insurance companies who pay for it?
No, patients.
They have to pay. The patients have to pay. So it's also a little bias in there. If you're honest, there's a little bias in there because no matter what the patient wants to prevent or the surgeon who is more a conservative surgeon, obviously trying to, let's say, I don't want to say it here open, but making a little bit more money out of conservative treatment before he gets up into surgery.
Yeah, but you have to give the chance to the patient to
I agree.
have the surgery at a later time.
No, of course, I agree. It's just a criticism of the system itself. It's the same in Germany and I think in most other countries.
Probably the whole world, yeah.
I assume, right? Well, but again, 2 important studies, and I think getting into conservative treatment more and more. I don't know if this is a road to success, but it makes sense because we're trying to prevent the final stage, which is a total joint or partial joint replacement. Agrees.
I mean, if you see the numbers before at Bence's presentation, I mean, how many primary surgeries have been in the last 20 years? I mean, the revision surgeries will be very, very high in the next 10 years.
True. For sure. Thank you so much.
Thank you very much.
Do we have any information about what type of tears? You mentioned medially or laterally, but do we have any information, the bucket list or bucket tear or root tear or anterior tear? What kind of tear we have in the meniscus?
Unfortunately, this one wasn't really specified in the articles, so we couldn't do any subgroup analysis. We would like to, but the data is not available.
I'd like to ask if you have information about that, if there were any meniscal repair that failed and needed meniscectomy later on.
Yeah, so one of the problems with meniscal repair is that it has a chance to failure, non-union, so non-healing, and in that case you have to do a surgery again. Obviously, with meniscectomy, this is not a problem, but with meniscal repair it can. On the literature, it's between 6 to 20%. So it's really varying depending on the articles. But also, maybe you have to make a revision surgery because of the rupture of the ACL, not for the meniscal injury. So that makes it even more difficult question.
Thank you, Gyula, for the nice presentation. Did you find any difference between the meniscal repair techniques during your literature search? I mean, all inside or inside out techniques? Because nowadays there are indications for the all inside technique also, but what I have seen that in all of the tiers you can use different techniques. It depends on the surgeon actually. So did you find any difference between the techniques? Or
unfortunately, my answer is as before. So they were not specified. So usually in the articles they said that we had 500 repair surgeries and I don't know 250 was inside out, the other half was outside out. So we couldn't do subgroup analysis, but it would be a very good question for the future.
Am I right that your means in the 2 groups are the changes?
Yes, from preoperative to postoperative results, yeah.
They were given in the articles or it was calculated and imputed?
No, given in the articles.
In all cases?
Yes.
Okay, it's good. And in all cases it was mean and not median?
So we had a lot of data, but a lot of articles didn't have preoperative data, just postoperative. So we only could do the meta-analysis in which cases we had at least 3 articles with good data. So in this case, as this is only 3 articles, we just separated lateral meniscus, medial meniscus. So this is 4 articles. So from the 22, it was very hard to, from the full 22 articles, it was 14 which had real data with what we could use.
And how did you access the heterogeneity?
With chi-square test.